best of the best to you all to educate you on what is new and what the leaders in the world are saying about caries management and whatever other topics are important to us. So today, I'm pleased and very proud, and we should all be recognize how important this is to have this person speak to us today, and you'll see why when I give this introduction. So today we have a 2-vaccine person who just received his 2nd dose. So he's given this talk hopefully before the antibodies start kicking in and give him a little twinge, but hopefully that doesn't happen. So today we're pleased to have Dr. J. Timothy Wright, DDS MS. Dr. Wright received his DDS degree from West Virginia University and completed his pediatric dentistry training and Master of Science degree at the University of Alabama at Birmingham. He currently is the Distinguished Bawden Professor in the Division of Pediatric and Public Health at the University of North Carolina, Chapel Hill, and has served as Pediatric Dentistry Department Chair and Department of Endodontics Department Interim Chair. He is a diplomat of the American Board of Pediatric Dentistry and a fellow of the American Academy for the Advancement of Science, and is the immediate past president of the AADR, that's the American Academy of Dental Research. Dr. Wright has published over 200 peer-reviewed scientific manuscripts, edited 2 texts, and authored 24 text chapters. Dr. Wright has recently been named the editor-in-chief of the Journal of the American Dental Association. And most importantly, I personally have found Dr. Wright to be a thoughtful and a good human being. Dr. Wright, take it away.
Thank you so much, Kevin. I wish we were in Florida too. I didn't even know that was an option. You should have waited till next year and had me do this. But no, thank you so much. And you can see I changed the title of what you had, and I actually changed this talk as early as this morning again. So it's morphing. I'm definitely going to talk about non-surgical caries management, aerosols, and put it in some context related to the pandemic. But I'm going to cover a gamut, and a lot of it I try to focus around things that you're interested in, and that you're out telling the stories and trying to educate and help the practicing dental community to provide optimal oral health care for the people that we serve. So this is kind of a caries management and where we are, where I think we are, and some opportunities even for the future. The way that, it's unfortunate that we're not in person in Florida, because the dialogue, I think, is what really enriches these things. So if you have questions or comments, that would be great. The way they're doing that is going to be in the chat, and then we'll, at the end of this, we'll have a discussion, or I'll try and answer questions, or we can discuss issues. So some of this is hopefully thought-provoking, related to the way that we manage caries in the population now. So you all know this, that dental caries is a very complex disease. And it's all these combination of factors go into determining whether you have it or you don't have it, and progression, trajectory, all of those kind of things. So there's all those things. We know the microbiome, and we know a lot more about it now than we did, but there's still an awful lot that we don't know. We know that there are environmental factors such as diet, fluoride exposure, illnesses, all kinds of other things, enamel defects, it's part of the host factors. Health, there's all the community and health and the individual. So the health literacy, family support, community support, access to care, all of these things, which is part of why it's so difficult to manage. There is no one thing that is going to get us, at least for a population base, is going to get us to health. What we're trying to do in the clinic is to figure out which of these factors are at play and which of those can we possibly impact to get patients on health trajectories, or keep them on a health trajectory. Maybe they're healthy. We want them to stay there. So those are kind of the issues that we deal with every day, managing dental caries in the population. So that's a kind of a framework. People have put together these kind of frameworks to help explain that, genetics, and again, the environmental, child influences, family, community. So this is the Fisher-Owens. There's a lot of different models like this. But it illustrates that, there's the biological, the genetic, but then there's also all these community socioeconomic factors that are critically important at the population level and the individual level, both of those. So again, that's what we're dealing with. This was a question I put, I did a talk on this. I've done a couple of these, and I would ask people, how has the pandemic changed, approaches to delivering preventive and oral health services? And in some cases it has, and some it hasn't. I think the dental practice, last thing I saw was that they're back to about 75% capacity. I think that's kind of where we are at the dental school. Some groups closer to that than other. Peds, we're pretty much back up. We may be higher than 75%, but somewhere in that ballpark. There were all kinds of things that came out, and I'll put some of that in a framework as far as new approaches to managing patients, especially when we were shut down for a couple of months. But even coming back, and how do we communicate with patients? What kind of services can we deliver? Trying to manage prevention, and all of those things have changed. I think it was a stimulus to bring on board some things that we had already in our wheelhouse, but we just maybe weren't using as optimally as we could, and probably still are in some respects. So when I looked online yesterday, there were 386,000 deaths to date. That's different now. I saw in the news last night, they were saying there was one person dying every 6 minutes in California or something. I mean, it's just unbelievable. So, we've learned a lot about this and how it spread, and the value of masks. And, in dentistry, we are an aerosol producing business. That's what we do. So that presents a lot of challenges. There's no way that you're not going to have aerosol if people are breathing. If they're talking or yelling, they're going to generate more. In my world, I'm not sure whether a high-speed handpiece generates more aerosol or a screaming 2-year-old who's spitting in my face. But either way, that's the world that we live in, and so I'm not sure that the protective equipment is ever going to change back to what it was before. I don't know. Well, it'd be interesting to see how this changes dentistry. Last big change I went through like this was the HIV, and that was when we really started. We didn't even wear gloves routinely prior to 1984, 85. So this I think is going to also have some long-lasting changes in the way we do business. And it's all related to these droplet aerosol and airborne, and we probably get all of those, droplets being probably the worst. But so again, high speeds, ultrasonics, thinking about how you have your office flow so that we know that they're contaminated. There have been several studies done on this, most of them previous to COVID, but some of this has been done in hospital rooms, where they've looked at if you've got a hospital room, what are the areas that are contaminated, and do you carry it out on your shoes and all this kind of things. Fortunately, most of it stays within the general vicinity of where you are, depending on how fast droplets fall out of the air and its size and all that stuff. But there's all kinds of new industries that popped up trying to manage this stuff. One of the things that, for this talk is, well, how can we avoid doing some of these things or minimize them so that you can localize it, schedule around these kind of things. And I think that's what a lot of practices are trying to do. I know we are, as far as socially distancing. If we're using ultrasonic, we're not doing it next to another patient. In our group, we're trying to bring in families and do some of these things to have efficient scheduling to be able to provide care, but take this into account so we're not spreading the vector around to ourselves or our patients or other families. So it's a challenge. I don't know if this is where dentistry headed. This is not what we're doing, but there's all these suction machines and all this kind of stuff. And I think part of this was at the beginning when people really didn't know, and there have been dental oral healthcare providers, dentists and assistants, and others who have contracted the virus. But given the number of patient contacts that have happened since March, more since the later when things opened back up in June, but there have been millions of dental services provided and very limited, if any. There aren't really reports outside of, there was a case in Wuhan, a couple of people, dental oral health people that got it, but very limited where they could actually show that it occurred in the dental setting and didn't occur outside. But this is my new suit, and I'm feeling pretty good about this. I like the looks of it. Kids like it. I'm like, Roger Ramjet or something. So it'll be interesting to see how these things can either continue or don't continue in the future. So that's kind of the context of the pandemic. And that'll come up a couple of other times as we roll through this. But so risk and resistance for all diseases, and caries is the focus, but it's true for most diseases that you have. Your risk and resistance really starts at conception with your genetic makeup, and there's not much you're going to do about that. There are environmental influences then that for most diseases you'll have environmental impact unless it's purely a hereditary disease. But even then, at the time of that conception, you're going to have environment is actually even influencing your genome at that point. So, where that egg gets fertilized, where it implants, the host mother, all of those things start from the get-go are going to change and modify the expression of those genes and who you are and what you are, nutrition, all of those kind of things. But genetics continues to play an important role in the risk and resistance to disease, and we're continuing to learn about that in dental caries. The heritability, depending on what kind of study you've done, twin studies would suggest it's as high as 50%. Usually I would ask and I'd say, how much do you think it is? And a lot of people think it's like 80% environment, 20% genetics. Some people say 50-50, some say the other, but the majority, and what I was trained with in West Virginia, it should have all been genetics, but at the time I went to dental school, we didn't think about that. It was all RC cola and moon pies. But genetics plays an important part, and there are, people who are really looking at this in a serious way has one component of that multifactorial. There's the genetics, there's the microbiome, all of these together to potentially come up with better predictors, because our current risk assessments are not particularly, they're helpful, and we do them, but they're not as accurate. The sensitivity and specificity aren't so good. Sensitivity can be pretty good if you just say everybody's going to have caries, because the majority of the population does. So you're going to be pretty right. But as far as being able to say which subset doesn't get caries or has a different kind of a caries pattern, that we're not so good at, given the tools that we have. So these hopefully will be informing us in the future as to better predicting what's going on and who's at risk, and then you could target therapies related to that. So caries phenotypes, I just kind of alluded to this. When you see this picture on the bottom, this is like the bad of the bad. When you see this is a 3 or 4 year old primary dentition and they got caries and lower incisors, you know that this is a super high risk. And so the dental phenotype of this, or the clinical manifestation, helps inform us as to what their trajectory has been. And the best predictor of what their trajectory is going to be is what it is or what it has been. That's people who get caries, who have them get them. They're set up for it. But we also know that Pitt and Fisher caries in this person and may not have anything else. That's a very different disease than what is the bottom picture. And we manage those different. If we think about them, which we should think about them differently, as to what it is and how it's going to potentially predict what their outcomes are going to be for the future. There's a lot of work going on in this. Well, not a lot of work, but there are multiple places. Mary Zeta, the Pittsburgh group, Kamunda Varis at UNC are looking at these different phenotypes, and also looking at how does this relate to the genetics, the microbiome, and again, predicting what you have, because I'm going to manage these very different. That Fisher may just be a sealant case. That lower case, you need to throw the kitchen sink at them, and even then, you might not be successful in putting out this fire. In fact, that kid right there, I treated in the operating room, did all this work. I didn't crown every single tooth, and a year later, the kid had some new caries, and the mother, who was a nurse, was irate, said, "I just had all this done a year ago, and they got new cavities." And I was like, "Well, kid's perfectly set up to get cavities. I mean, they got all the right mix in here." And the mom said, "Well, they've got an average American diet." And I was like, "Well, that could be part of the problem." So anyway, different phenotypes. This has been the party line for years. This really came about in the 70s and 80s. It started in the 60s. Caries was an infectious and transmissible disease. Paul Caries, who did this work with germ-free animals at the NIH, and it was considered seminal work because he showed that if you put the bacteria like strep mutans or lactobacillus in there and fed an animal sugar, they would develop caries. And then if you put them in a cage with a germ-free animal, they would transmit it. So thus it was satisfying Koch's postulates that this is an infectious and transmissible disease. But we know it's really not like that. It's not like Ebola. It's not these bugs that we have, the germs that, and it's not just strep mutans and it's not just lactobacillus, it's the biofilm that we do get it. It's transmitted. We're not born with all of it. We're born with a little bit of it. It now looks like some of it actually is transmitted in utero, which they didn't think 10 years ago or even 5 years ago. Most people thought it was a sterile environment, but it's apparently not. But it's not a traditional transmissible disease, even though a lot of people have tried to treat it as such. And there was a lot of work in the 80s and 90s to try and stop transmission of the biofilm, the bugs of the microbiome. And nothing showed to be effective with that. You can chew gum, do whatever, but the biofilm is going to be there. And that's not surprising since we've co-evolved for millions of years to be together. We usually like to be together, and it doesn't cause a problem. So there's issues related to transmission and what that is. It's very diverse. There are 2,000 different microbial species in the mouth, like 700 bacteria, but there's all kinds of other things in there in the microbiome. And just now learning the importance of things like Candida that's in there and the role that it apparently is playing. I mean, we know it's associated. I don't know specifically the role, but the biofilm, it's like a whole other little micro world in your mouth of all these different bugs that are in there hanging out together. And if you have dysbiosis or you get them out of kilter, you get them out of the quantities, and so they're not balanced anymore. That's when you have disease. You knock off the bacteria, you'll have fungal overgrowth, get Candida. This is true in the gut, in the GI system, and in the mouth. There's very little out there, but people are now starting to look at, and have been for a few years, metabolomics. So what's the microbiome doing? There's the whole issue of the interrelationship, interaction between the human genome and the microbiome, and that's an individually different thing. So there's an awful lot of research going on that's really changing the way that we understand caries and some of these complexities, which is, people have focused on strep mutans for years, and as we learn about the microbiome and the complexity of the biofilm, that's not even considered a big, huge key player. There's still studies that show that it is associated with high caries. If you have high caries, you tend to have high strep mutans. Not everybody, but at population level, you usually see that. But that's not necessarily a cause and effect. And other players have been looked at as being probably even more important. And those bugs tend to have really big, long names that are hard to remember and hard to pronounce. So your microbiome, again, we get this as babies, and it evolves throughout life, and most of it, there's more of them on us and in us than there are of our own human cells by a long shot. So again, we've co-evolved to survive together. Bugs don't want to kill you off because you're the vector. You're the one that allows them to survive. So it's not in their best interest to kill us. So from birth, if you're a vaginal birth and you're automatically exposed through that, even a cesarean, they're usually going to take you out and lay you down on the skin of the mother. You're going to breastfeed. So as we march through our trajectory of life and go through our life cycle, we continue to change and diversify our biome. So diversity goes up, individual variability kind of goes down. It's higher earlier on. So this is normal. This is what it should be. So trying to stop, I was involved in the mother-infant transmission study to stop strep mutans transmission from mothers to kids using fluoride, iodine, and very aggressive restorative sealants, which didn't work. It didn't stop transmission. The kids all got transmitted. These were high caries risk mothers that had given birth. They were followed from birth through a couple of years. Paige Caulfield was the PI on that study. But anyway, so carbohydrate metabolism in this on the graph on the right, you can see these studies now looking at the different bugs. This is kind of where the rubber hits the road. So if you've got a lot of carbohydrate metabolism, the caries people are much higher than the other people, than the caries-free people. Not surprising. And you can see the bugs, there's all kinds of different strains in here that will be up or down depending on, the Prevotella, and there's others that are in there. Again, a lot of these big long names, but these are enriched. In fact, they've identified new species, and then a lot of this has happened because of the technology where we now have these molecular-based assays, and we're not having to cultivate everything in a petri dish, which a lot of things don't grow. So when they go do this and they're looking at the RNA or DNA, the bacteria and the microbes, not just the bacteria, but all the microorganisms, they identify all kinds of things that nobody even knows what they are because they've got sequence in there that's not in any data bank that says, oh yeah, that's a lacto, or that's a this, or that's a that. So it's been interesting, the microbiome project, to see how that's moved us forward in our knowledge of all of this. So again, is it an infectious and transmissible disease? We know it's very diverse. We know it's dysbiosis that really gets you there. And you've got this very diverse, the oral orifice, the GI system is the most diverse microbiome in the mouth and in the body. So it's not traditional transmission that we think of. So it's not in the classic sense. And you really, in my opinion, is you don't want to stop transmission. Those bugs are there for a reason. You just don't want to get them out of kilter and have the dysbiosis. So strep mutans, lactobacillus, all these things that are commensal. But if you eat a whole lot of sugar, then you're going to have a whole lot of the acidogenic bacteria that are going to overpopulate, and at the expense of healthy ones that keep them in balance. And some of those, and they're doing some of these studies now, they're actually finding that the good bacteria having high levels of that are more associated with health than like the low levels of strep mutans. So again, we're learning a lot about this. So, we were in pediatric dentistry saying, don't kiss your kids, don't taste their food. And I had discussions and with folks back then, and I said, the best transmission you're going to get is from your mother. If you're breastfeeding, you have antibodies against that, and you're not going to stop them anyway. So, all of the time we spent on this was based on a couple of not big clinical trials or anything, but observations that if you were kissing your babies and doing this, they were more likely to have cavities. But they weren't cause and effect kind of studies. There was another study that came out not too long ago about mothers who licked off pacifiers if they fell on the ground versus those that re-sterilized them. The kids that had the moms lick them off were significantly less likely to have eczema, which is kind of an autoimmune thing, and asthma. They didn't do a Caries study, but it was interesting because it was showing that the kids that were more exposed to these different bacteria, their body were using their immune system to fight that off. And the dental people got up in arms about that and said, look, they're transferring all the bacteria. And I said, well, actually, they're illustrating that transfer from mother to infant is probably a good thing in overall health. So anyway, that was not time well spent. One of the things in doing prevention is target the stuff that you can impact that's going to be meaningful, and the other stuff, forget it, because they're not going to do 90% of what we tell them. If you can get them, figure out what is the one thing that you're going to impact, or two things that's going to be most meaningful, that's going to fit within the context of those people's lives. I asked myself this question: did sugar go up? And my hypothesis was it would go up in the pandemic because people were sitting around eating donuts or whatever. The reality, from what I've been able to read, I haven't seen publications on it, but just off websites, is that it actually has decreased sugar consumption based on market. It's actually declined, and they said a lot of the reason was people weren't going out and eating and going to quick rips and places and buying up all kinds of drinks, largely drinks, was driving a lot of it. So apparently it's actually gone down. I think most of us predicted that during the pandemic, this would go up, caries would go up, and there would be a big problem. Don't know about the caries part, but sugar consumption apparently did not go up, maybe actually declined. That was preliminary of what I've seen. So sugar, though, we know, in the average American diet, this is data from US data, and 2/3 drink at least one sugar sweetened beverage every day. Back in the day, I used to ask about chewing gum and sugar chewing gum, but these are the juice and soft drink sugar sweetened beverages are the big drivers for a lot of this frequent consumption. And almost always for my rampant caries cases, sometimes here in the South it's sweet tea, but soft drinks and juices tend to be the two big hits. So those are my first questions. If I've got rampant caries cases, what do you liking to drink? What's your favorite? Do you like to do the dew or whatever they're drinking? Kids, that's not an uncommon one. But yesterday, one of the kids I saw a lot of caries, it was Dr. Pepper and ginger ale. Ginger ale is not so common, but anyway. Historically, how in dentistry we thought about controlling caries? Well, surgical removal. I mean, and I even had a resident say this the other day. It was like, yeah, I'm going to go in and remove all the sites of infection, thinking that you're going to sterilize the mouth by doing fillings. And we know that's not true. And you're not even going to change the trajectory of disease really by doing fillings. If you pull all the teeth out, you will. But if you're doing fillings and there's still natural tooth structure, they're still at risk for getting new disease or disease under existing fillings. Mechanical, we spend a lot of time talking about oral hygiene, doing prophies and those kind of things. Sealants is a mechanical obturation, restorations, and if you cover them up with crowns or that does provide some removal. If you're removal bacterial-laden dentin, which tends to be loaded up with lactobacillus, you will change the oral ecology by doing that, but that also tends to be transient. And things that live on the surface, like strep mutans, they come back very quickly and they'll grow on any restorative material you have. None of them, well, there are some new antimicrobial ones, and I have that down there, antimicrobial materials, and there's a lot of work been done in this area, and that's an emerging area. People, the ideal restorative materials would be strong, they'd be aesthetic, they would remineralize, they would have antibacterial properties. Your company, you guys have the cell docs and a couple of things, the sealants and the surface sealant. So those are interesting directions. Chemotherapeutic, there's more than this. Obviously, people have used a variety of chemotherapeutics, iodine, silver-diamine fluoride, silver nitrate, a variety of things, chlorhexidine, so on. Clorox, sodium hypochlorite. There's rinses with. I think that you can do like up to 0.3% sodium hypochlorite in a rinse, an oral rinse. And it's very, it's not only antibacterial, but it's also antiviral. That's why we use Clorox wipes and stuff for the COVID. Silver is actually very effective. If you look at I think it's the CDC website that has all the listings of all the different antimicrobials and their effect on COVID. And silver's one, sodium hypochlorite another. If you want to change the oral biofilm and the dysbiosis, diet is what's driving that. If you change the diet, reduce the sugar intake, you will change it. Still an awful lot of people that are going with the restorative route thinking that they're changing the environment, the ecology. So caries is chronic, and our goal is to not get them on a health trajectory, and we have to work in the pediatric world with the parents and the patients, and that transitions over time as they're going through the life cycle. It's very different in a 2-year-old than it is in a 10-year-old than it is an 18-year-old. And it's throughout the life cycle, it's very changing. Your risks and even your defenses are going to change over time. That's why doing risk assessment and talking about what's going on is important. You don't just do a preventive plan and you're one and done. It's every time you see them, you need to have those discussions because it's a moving target. So trying to get them to either stay on a good health trajectory or move them to one is the challenge, and finding out again what fits within the context of those people's lives. And some people are just not going to be able to do it. If you've got a whole bunch of kids and you've got a job and you're coming home or you're working at night and you're switching parents or whatever it is, it's how does it fit within the context of that family? That's the challenge to person-centered care and family-centered care that we face in the clinics. And so you have to have those discussions and dialogues. And I feel like a used car salesman sometimes. It's like, what can I do to put you in good oral health today? I got a Volkswagen Beetle and I've got a Mercedes Benz, but I could do these things. I got this, and this. Which one could you do? Could it be to drink fluoridated water? Could it be brush once a night with fluoridated toothpaste? Whatever. And then you fit the armamentarium we have with what's going to hopefully work for them. then you reassess your recalls and you redo it again. You look at it and keep tweaking it until you get them healthy. This is a composite slide that I developed on Caries. It's a trajectory, and where you are on this trajectory will depend on what you might use for therapeutics and interventions. So beginning, not all teeth, but hopefully most teeth, many teeth. Some have enamel defects and other developmental issues, but the enamel crystallites are well mineralized, well shaped, densely packed, and it's mostly mineral. A little bit of protein, a little bit of water, a little bit of space, but as we move forward, and if we have demineralization, we'll have the IC-DOS 1s and 2s. They continue to have issues. They'll move on to 3s and 4s, and on up the scale. So each one of these, this is keep them on a health trajectory. If you start to have these kind of lesions, they're not cavitated, but it's caries. And some practicing dentists don't even, they call them white spots, and we'll keep a watch on them. It's like, well, you've got disease. This is disease, and you need to. If you don't intervene and you don't change the game, unless it just happens serendipitously, you can expect them to continue to progress. They're not playing a winning game. So this is an electron micrograph showing how the crystallites start to dissolve inside, and they get sharp and pointy. They're dissolving on the edges. So this is where we want to be, but we have things in our armamentarium all the way across here that we can use to intervene. So IC-DOS systems, I think these are important for dental people to think about, because it gives you an idea of where you are in the spectrum and where you can be, what you may be doing. So what your interventions may be. So, there's eyeballs still for pits and fissures. Eyeballs still tends to be the best thing that's out there, as opposed to explorers, which are still heavily used in dental practices. It's sticky, I'm going to drill it. We know that that's not a good assessment. There's many studies on that. There are other things that are out there. There's a whole bunch of different systems that are out there. I'm sure you're familiar with. I know Kevin actually was involved in some of these, the QLF and others, the Inspector Pro. So we still don't have an ideal one. Some of them are they can be expensive. They cannot be necessarily user friendly, but hopefully at some point in time we'll have a little better than the eyeball stuff, and we probably already do, but they're not mainstream in most dental practices. The early detection, though, is what allows you to have interventions early on that are on the preventive spectrum to keep them out of health. So in my opinion, the earlier you can detect it, the better you are, because it's providing information to how to optimize your prevention or secondary prevention. You've got early disease, let's stop it, reverse it, and go that route, as opposed to having to get to the restorative world. So looking at the lesions, is it a lesion? Detect it. What is the severity of the lesion, and is it active or not active? I've seen pictures like this, and it'll be some caries diagnostic, and they'll show a picture like this, and here's the sound dentin below this, and usually the caries is on the walls of this, but you take an Explorer and it'll stop about right here, and it'll stick if you push it hard, because they just do. I mean, if it was made out of steel and you pushed it down in there, it would eventually bind, it wouldn't come back up. And they'll say, yeah, see, this has caries, so you should go in and restore this, and you could do an enamelplasty, blah, blah, blah. Well, it's not to the DEJ, even at this point. This is what you should be sealing. Most pit and fissures are going to have some caries activity in there, just because our cycle of remin, demin is, unless you have no carbohydrates, you have a G tube or something. So these are important things to consider, and dentistry still tends to use Explorers too much, instead of just looking at it and making a call. If it's not shadow, it's not undermined. The fact that it's stained and it may even look uncoalesced, many fissures are not. That's just the developmental process, and they'll take up stain. They'll have organic material in here, but you don't necessarily have to drill this out. Now, one might say, well, this one looks a little shattered. And that's where you get into making a judgment call. Unfortunately, the judgment call frequently, and this was like, there was a paper that was published from the Practice-Based Research Network. General dentists tended not to even consider sealants. They'd put a watch on this. They might say, we'll do fluoride on it. About half of them went in and they actually monitored these and said, are they caries or not caries? About half of them that opened them up, they said they were not caries. So they were calling an awful lot of them as they were providing surgical intervention when they were they were calling them wrong. They didn't need to be surgically intervened. That's pervasive still in dentistry today. Room for improvement. So again, diagnosis is important, radiographically the same. I've had people say, well, I'm not going to do anything until it's big enough for me to, put a filling in. Well, when I see these kind of lesions, this is where I want to intervene for sure. If you don't intervene, they will get bigger. So what can you do? And there's a variety of things, and I'm going to talk specifically about white spot lesions. But diagnosing these, the point here is it's important to do this because that's what drives your changing your preventive care. So things that we can do as far as reduced aerosol caries management, optimizing prevention, that's key. So there was a lot of that we were doing during the early, especially during the lockdown, we were actually calling and talking to patients, teledentistry and doing that. But we have all of these different mechanisms of managing caries with low. It's not no aerosol. I used to have non-aerosol. It's reduced. Again, if they're breathing, toothbrush, anything that you're doing is going to generate some aerosol. Toothbrush could be pretty sloppy with droplets, depending on how you rake it around. And then even some restorative approaches where you can do these non-surgically. So I'm going to mention those too as we move on. All kinds of challenges. You got the whole age spectrum. Special needs patients, the elderly, the nursing homes right now is huge. I mean, that's a great opportunity for therapeutics like SDF to get into nursing homes and places where super high risk and very high death rates from COVID in these homes. They've just gone rampant through them because of the design of nursing homes where they've got multiple people in rooms and, anyway, contact through them. So that hasn't played out very well, but they still need oral health care. A lot of them haven't been getting it. So that's an issue. And there are therapeutics out there. So teledentistry consults, optimizing fluorides. We were recommending a lot of 5,000 ppms, rinses, trying to do everything that we could to talk to people and make sure that during this time, if they weren't able to get in, we weren't able to get them in, that we were still in touch with them and talking to them about their oral health and what their needs and the issues were. So those are hopefully some things that people will continue to do post-pandemic, I'm hoping. Again, antimicrobial approaches, drilling them out was sort of where we were for many, many years, but people recognized, again, after the 1960s, that this was a biofilm-mediated disease. Didn't understand all of that, but we knew that's what it was. In fact, that's not a new concept. Back in the 1800s, Miller proposed that from the get-go. So that's not a new concept. We've learned a lot about it. Chlorhexidine, Canberra people recommending that. Povidone is out there. SDF, silver nitrate, and others. And some of these have been shown to be effective and others not. Chlorhexidine at the concentrations that have been used around the world, and we use a 0.12, but even 0.2 in Europe, they're not effective against caries. Iodine, there's data out there. There's some that are showing that it has some benefit and others not. SDF clearly does, silver nitrate clearly does. So there are options. These guys, well, chlorhexidine is usually used as a rinse. And so you're globally trying to shotgun and kill everything off. You're just trying to suppress everything. Again, I don't think that's what you should be trying to do. But if you use povidone iodine as a rinse, and most of it's 10% betadine, that would be a shotgun approach. But there's a lot of people now that are using this where they're swabbing it directly on the teeth, and that's more of a localized thing. And people are doing it generalized, just not on the lesion. SDF is now both. There's actually the new code for that. You can use it as a primary prevention, but most people aren't slathering it over the entire dentition. But these are more focused when you start to do that. Silver nitrate, same things. You're treating lesions or local areas, maybe pit and fissures you're trying to prevent caries. So I'm not a fan of shotgun approach, these kind of things, but I am a fan of trying to do it localized or more concentrated on the dentition to suppress the biofilms activity in those areas where you are at risk of or are getting caries. Exposed roots, pits and fissures, that kind of stuff. Paradex, again, yeah. And the systematic reviews on this have looked at this, and I know John Featherstone didn't like it when I made the comment. We published the paper, was the ADA systematic review, but it was one of the strongest recommendations we had. It just doesn't, it's not effective. It's expensive. It's a prescription item. It stains teeth. So there's better options. So, and I think Cameron still has it for the really high risk people, but it doesn't matter. That it doesn't. There's no evidence that it works in those people. So I personally would never prescribe that unless they got, they got gingivitis or they have candidiasis or they have stomatitis and they're a cancer patient. That's what it was marketed. That's what it was developed for. That's how it came through the FDA, was an orphan disease for cancer patients. So iodine, again, it's inexpensive, readily available. There is some clinical data. It's not real definitive. I know that Peter Milgram recently published a clinical trial from his Micronesia populations that he did the xylitol studies on. That, and I've got another slide on that, shows some effectiveness, but not equivocal in my mind. There are swabs and things that are out there. Most of these, like betadine, is 10% povidone iodine. There's a company in Florida that's selling the higher concentration of the I2, which doesn't have all the other iodine, the triiodos and the other ones that cause some of the staining and the discoloration and some of those things. But I think, to me, this is a story that's emerging. There's currently no guidelines that recommend it because there's just not enough clinical data out there to pull the trigger on it. And it'll be interesting to see how this story evolves. But there was a study, I got this off of from a study that was done. It wasn't a randomized trial, but they were using iodine and then they would put varnish on. They would swab the teeth with the iodine, then they would go in, so disinfect, and then they come back with the sodium fluoride. Their control group was kids who didn't get anything but fluoride toothpaste. So that's not exactly the gold standard of control. It should be the best last available treatment. So they should have at least been getting varnish. I'm surprised they could even do a study like that ethically. But anyway, that's kind of some of what we know and don't know about that. So this was the Milgram study that was published just not too long. I think it was October maybe. And they compared a 10% povidone varnish combo that they made up. It was a 2-year study. They started with 284, had 262, and they ended at 2 years, which is pretty good. It's an island. I guess they don't leave very often, but they didn't show any significant difference when they looked at all teeth. There were significant differences when there was no significant difference if you looked at the molars. When you looked at all teeth, there was a 0.7% DMFS difference. So it was significant. So it was like 2 and 2.7 overall for them. So you did have some reduction. So some indication that it might benefit. But there were some issues. They did not use an intention to treat analysis. And they said, we didn't think it would change it, but they should have done it anyway. 20 people probably wouldn't change. But that's sort of the gold standard of how you should do these things. So again, evidence emerging. I knew this trial had been in the books for a good bit, and I'm glad to see that Peter Milgram continues to push the envelope and think about these things. So it'll be interesting to see how it plays out with more data. Looking back again at the viral load and COVID, and people have used some of these same kind of things to look at if you did a pre-rinse, and a lot of offices were doing this stuff. Hydrogen peroxide, Colgate's got I don't remember what it is. I think it's 1.5%. 3 is what you'd normally buy in a bottle if you were at the drugstore. But these do kill off the virus. There is no evidence to show that if you have people do this, that it actually prevents transmission to the staff in the office. If you're wearing N95 masks and face shields and all that stuff, spacesuits like we're doing, that's what we're doing, I don't think that this really makes any difference. I've heard some people say that these things were terrible and disgusting to have to do, but we're not doing it at our school. I don't know how many places are doing this. I haven't seen any studies on this, but there are studies showing that these can be effective against COVID. So that's out there too. Xylitol, I'm not going to say a whole lot about this. There's multiple systematic reviews. This is one showing that it's not significant because it still crosses the null, hits the null. If you look at most studies, I mean, if you looked at all of it, there's some low level of evidence that there may be some benefit, but as far as being a great thing that's going to really change the trajectory for most people. Probably not. It's not antibacterial in the sense that it kills the bacteria, but they can't use it for anything. And there's evidence in general health too. It's been used for nasal and a variety of other things. So it started as a big, this is going to sort of save the world. Maybe not that, maybe not quite that far. That might be an exaggeration. It's going to be a huge tool, and it's sort of come to not be such a huge tool. If you look at chewing gum studies, where a lot of that data is, there's a systematic review that I think was published in the last couple of years. It was showing 20 some percent to, the high of 38, 40%, something like that. So, I mean, it's something you could do. Chewing gum, we know, stimulates saliva, and that helps, and you don't want anything in there that's fermentable. Xylitol is not, sorbitol is a little bit. So, it's something that could be recommended. As far as dosing, I do have this issue, and I've talked to Peter Milgram about this because he did the xylitol syrup studies in the Micronesia. And I said, Peter, do you have any concern about giving 9-month-old children super sweet syrup to drink when they're developing their taste preferences for life? And that is not evolutionarily what we would be giving 9 months old. And he said, I never really thought about it. I said, I think you should. I have a concern about that. Spiffies is another one. Wiping newborns' mouths out with super sweet stuff. That is not the taste preference that you necessarily want people to develop. So again, you're kind of messing around with the evolutionary diet. Normally it's mother's breast milk would be the ideal. That's as sweet as it gets at sort of the earlier part, not at 9 months. You're switching over. But again, drinking sweet syrup, super sweet syrup, I don't think that's a good idea. I think there's other ways to get to the end point of caries control without doing that. It'll be interesting to see if those kids all look like the Michelin Man when they grow up. So quality of evidence is not super great for the xylitol stuff. And I know you guys you market the Epic, but telling you my take. Silver salts, there's 3 things at least on the market in the United States. These are 3 that I know of. So you guys first with the SDF, and then Riva came out, I don't know, a year or 2 ago now. Silver nitrate's been around forever. Now was used as house solution back in the 30s and 40s and stuff. It's been around a long time, and it's been around for a lot of other applications way before that. So that's what's on the market that's out there. You guys know all this, but silver is super antimicrobial, and people have known that for years, and it is such because it hits microbes through a variety of different mechanisms, cell wall, the dysfunctions, the organelles inside. It messes with enzyme systems, with the replication and the molecular apparatus for DNA and stuff like that. So it's a killer. But fortunately, it doesn't do this to human cells, which is why it's pretty safe, and it has a really quite broad acute toxicity. I mean, you'd have to take an awful lot of silver to kill yourself. You'd have to eat a lot of jewelry or something. What's it do to biofilm? There's still not a lot of, there's not like global data. If you did this on the total oral ecology, what is it going to really change it? The data that's out there, and the people that I've talked to said, if you look, 6 months out, if you treated a whole bunch of lesions with SDF and you looked at them before biofilm and after biofilm, overall, like in the saliva, it's probably not going to be much different. It's not going to change it a whole lot. Changes it dramatically within the lesion because it kills the bugs and it remineralizes in that lesion. So locally, and I like that, it's a local effect. It's not a global effect. And that's important in 2 reasons. One is you're not messing with the overall ecology of the biofilm, but you are locally, and but it also is telling you if you don't do something to change the overall biofilm that got you where you were, you don't change you need to change partners in this dance, or you're going to end up at the same prom with new cavities. So SDF, you guys know this, so it's antimicrobial and remineralized, so you got a double whammy, which is why we immediately switched from silver nitrate to this when this came on the market. I think I saw Kevin at the Academy meeting that year, and I didn't know it had hit the market. It had only been out for a couple of months, and I think he sent me a bottle right after that, and we immediately switched because there was more data on it. There were randomized controlled trials, and there wasn't much out there on silver nitrate. We knew it worked, but So we switched. This was actually a silver nitrate before and after. So we were already down this road before SDF hit the market in the United States, but we thought it was a great addition and have been using it substantially ever since. I get a lot of questions about pulp. There have been a number of histology studies, both in animals and in humans, and it's not an irritant in and of itself so much. Now, there is some issues. People have talked about the REVA on that because of the pH and the differences there. But with the formulation that you guys use, there's not a lot, it doesn't seem to be a lot of inflammation associated with it. So I have people like, well, if it's really deep, is it gonna, if you have really deep caries, is it gonna irritate the pulp and that's gonna be a problem? I said, well, the data wouldn't really suggest that it is. And studies do show it's not a pulp capping. You don't want to put it directly on the pulp and think that it's going to heal it. It's not. So it doesn't work in that respect. But I have deep carious lesions, and we're screening them for the operating room. I tell the residents, like, what do you got to lose? Put it on there. Maybe you'll prevent pulpal involvement, and you can restore the tooth later on. Sedation, OR, those kind of kids. Or you do it on first visit, and they got a mouthful of decay. You're trying to control the caries, and they're really deep. Put it on them. If they're going to abscess, they're probably already headed south. They're going to abscess. The safety data. There's other studies on this. So this was an adult. So I'm sure in the kids, especially people slathering it on too much and running it all over, they may be exceeding this. But the fluoride levels in these studies were not excessive. And again, the silver, you'd have to do this repeatedly to cause, because it's a cumulative chronic exposure. The acute exposures you got to be pretty high to have a problem. So this, it stains. This is actually silver nitrate. You get more of a brown henna from that if it's chronic consumption. This is a patient I had with a hereditary skin thing. They use Silvadene cream, which is a silver antibiotic, and silver dyed. I'm spacing on the name of the actual antibiotic part. What you don't maybe know is, if you get this on a patient, I had this happen in the operating room last week. We were treating incipient lesions proximally with SDF, restoring some teeth, and then proximal, we'd open them up and see a white spot lesion, we hit them with SDF, and it got on the kid's lip. And so there was this, and the big OR lights are lighting it up, so it's turning dark really quickly. If you take sodium hypochlorite, put it on a cotton swab, and I've done this on my own hand, you guys can do this. You can try this at home. Put some on your hand, let it sit for half an hour, hit it with a light, get it really nice and dark. Take some sodium hypochlorite just straight out of the bottle on a cotton swab and wipe it on there, and it'll come off in 30 seconds, 10 seconds, 30 seconds. It'll clean it up really well. I've heard hydrogen peroxide works as well, but I'm a sodium hypochlorite kind of a guy, so this is a good cleanup. If you get it on a lip or you tattoo a neck, you get it on your hands, whatever, and it's not, you don't have to do it immediately before you can see it. It still works. I haven't done it for hours, but it'll take it right off. And this doesn't burn your skin or anything, unless I suppose you were sensitive to it, but I've never had an issue with that. So there's a little trick you can have. I've heard that the magic eraser will work on countertops and things. I've tried that the 2 times, not 4 times. It helped a little bit. It didn't get off a really old one that we had on one of our counters. All these possible advantages to this. In this context of the pandemic, it's very low aerosol producing, so you don't have to excavate, you don't have to use hand pieces. When I dry these, I don't actually even use that was the thing that came out in the blog. People are hitting it in the air because it says the air dry, and as people were blasting it and blowing it all over the place, it's like, well, when I do that, what I do is pick up a cotton pledget, make sure I've taken out the excess, and that's the drying that I do. So if you're blasting it with a 3-way air syringe and hitting it with the air really hard, then you're generating droplets from doing that, and you don't need to do that anyway. So I just use a cotton pledget. So pretty low aerosol. So if you're trying to do caries management, you don't have to go in there with drilling and filling and doing all that stuff if you're doing SDF. So that could be an advantage. Another one in the context of pandemic. Case selection, obviously important. Got to get consent. People got to want to do it. I don't always ask kids what they think about it. If they're older, I do, but and special needs maybe not. But got to consent. This was the very first paper. This was Yasmin Crystals, and you know this stuff about, and there's now systematic review on this that sort of just recapitulates this, or, you know, sort of same conclusions. Back teeth better than front teeth. Boys more acceptable than girls, I guess, because they can like play pirates at Halloween if they've got black front teeth or something. But that data is held pretty well. I tell you my own personal experience is I've only had a couple. I mean, really, you count them on one hand the number of people who've said no to me, and maybe that's because of the way I present it with the options. I had a resident who did a study, we haven't published it yet, where she used the Ohio State behavior management scenarios and did that in the context of, would you rather have SDF or would you rather have surgical management? And we have to use these techniques. And when you got into restraint, sedation, and general anesthesia, they were much more likely to pick SDF. Then we said, well, here's the outcomes. So we got that answer first, and then we said, well, here's what the teeth look like with the two. And then we showed them SDF with black teeth, and we showed them strip crowns and zirconia crowns. And then they're like, oh, I like the way those look a lot better. So, you know, there is that in our society that's driven. And I made a point that I make to people is it's not one or the other. I mean, you could still do SDF, and maybe you're getting them so you've got them to where they're older, and you're not doing a GA on a 2-year-old, you're doing it on a 4-year-old when they've got more neurological development, they're larger, they're healthier, whatever. So, but that was a study that we did to put it in that context. Usually parents, if they've got going to have to use those kind of techniques, though, they'd rather go non-invasive or non-surgical, operating room if they could get away with that. This is what our protocol is. We see them back in 2 to 6 weeks because we know that we don't get 100% arrest. Even with two times you don't, but you get really high. But we reevaluate. And to me, most importantly, I mean, we won't reapply if we need to, but we got to change their health trajectory, because this is not going to do it in and of itself. We're going to re-message everything and really work to try and push them into a health trajectory. So that's why we do it. There's multiple, we thought this was important when we did this work, because there wasn't a guideline that said this was okay. And I had discussions with people in the academy. They said, well, I'm going to have problems with this. You know, people are going to take me to court because I'm turning their teeth black, and that's not the standard of care. And I said, there really is no standard of care for caries. There isn't, and that's a legal definition. But if you talk to 10 pediatric dentists, even at that time when SDF, even when we're doing silver nitrate, because we did this actually with Mike Canellis and a bunch of people out in the Washington, in Oregon, actually, with the Indian Health Service and people that were Steve Duffin and people that were working there. We had a bunch of people, even internationally, pediatric dentists in scenarios like 2-year-old, what would you do? And it was everything from, we put at that time silver nitrate to we take them to the operating room. So there was no standard within that group that we went through. So at this point, this is a discussion I've had with Academy people, is if you don't offer this as an alternative and your risk benefits an alternative, when you get informed consent for sedation or operating room, if this is a reasonable, viable option, and I told them in a meeting, I was up at the podium and this came up, and I said, you know, this is an alternative and it should be part of informed consent. And if you don't offer it and that kid dies, I might be the person across from you who's going to challenge you that you didn't actually offer this as an alternative to surgical management, if it's appropriate. Kids got abscess teeth and stuff, that's not appropriate. It's not going to manage that. But there's an awful lot of cases where it would be. So I used to have 4 options for informed consent. This wasn't one of them. Now I have 5. And so this is a routine part of my informed consent. Having this was helpful. Even internationally, I was in Dubai and they said, we can't recommend it because there's no guideline that supports it. So this, I think, was an important publication. It was the first one out there that said this is useful and should be part of your armamentarium. ADA, when you looked at these, and I know you know these guidelines, but these papers that came out in 2018, it was like all roads lead to SDF, you know, and for both primary and permanent. They had the root caries and the permanent. So there's actually probably a couple of arrows that one could now say non-cavitated occlusals, there's evidence that school-based studies where they get, it's like 64% preventive fraction with early treatment with SDF as a primary. So that would be that 1355 code. So again, it certainly has taken a place, and now you've got multiple recommendations, systematic reviews, and guidelines to support this approach. And you can see some of the other ones that were in here. I was kind of surprised, resin infiltration, but there are multiple randomized controlled trials that are in here that gets it there. I'm going to talk a little bit about white spot lesions. So there's lots of different, you can have many places pretty much. They're usually either below contacts or around the gingiva. These, if this kid stops having the challenge of demineralizing as these teeth erupt and the gingiva recedes, these may be closer, higher up, and there'll be fresh, not demineralized tooth below it if you change their trajectory. How you manage these is somewhat dependent on where they are, the cause, all the other factors that go into this. You have a variety of options. Unfortunately, there's still a lot of this. Even the computer programs and electronic health records like Dentrix and some of these have a little eye with you put it over the tooth and say, I would put a watch on that. I get on my soapbox about that. He's like, this is not a voyeur sport here. This is an intervention. This is telling you there's disease, you need to do something. So sealants for pits and fissures, resin perfusion. I personally don't. I do this, but I do it in a different kind of way. I don't use icon system much. I don't use it at all for white spot lesions like this. SDF. There's some evidence on this. There's the only paper, and there may be a new one Kevin knows about, but the Hammerstrom paper from Ohio State. Again, there's not randomized controlled trials, but and a lot of anecdotal evidence talking to practitioners that they're doing this, Janet McLean approaches with superfloss or however you want to do this, and varnish. This is not a good one. It's not a watch thing. I have a real problem with that. This is a kid that I treated. I did SDF here. I did SDF, and then I came back with classinotomy restorations on these. So what I didn't know, and you could sort of discern there might be some demineralization. When the tooth fell out, he had this. He asked me, he said, what is this black spot here on my tooth? I said, well, that's where you were getting a cavity on there when I put that fluoride silver in there that stopped the decay on the baby tooth. It stopped it on this tooth. So now it's all nice and solid and hard. The kid actually thanked me, which I was glad. But people need to be aware if you're doing this up and you can't see it, and it wasn't all that open at the time. I should have been able to see it, but it probably was down here, real low, and I didn't see it. That could be something that happened. In the posterior, I'm tickled about this. This is great. I mean, I've arrested a lesion on this and made it really rock hard. Dark and hard is the endpoint for arrested decay. Whether it's SDF, fluoride, or otherwise, that's the endpoint. And both of these actually stayed until they fell out and no other problem. So it was kind of a gentler way. And it's a pretty big lesion, and I didn't kill the pulp with this. So anyway. Ortho lesions are different. We see a lot of this, and people will do, talk about remineralized MI paste. This is as good as toothpaste. That's what all the data would suggest. So again, and it's expensive. I don't recommend this. If somebody gave me a free sample, I might give it to somebody, but and if they're anti-fluoride and this is the plus with 900 ppm, I might say, yeah, you could give it a go. But it's a cool idea, but it doesn't work any better than just regular over-the-counter toothpaste. Ortho people a lot of times will try and bleach around these and sort of mask them out. Microabrasion, infiltration, all of these things are out there. I've tried all of them, and these will work selectively. But to me, the big thing to do is this: prevent it in the first place. That's what you should be doing. This kid shouldn't probably be in braces. I mean, this kid should be debracketed and get this kid out of here because you know where he's headed. Your product, and maybe you have data, I just haven't seen it in here, but this whole idea of a surface sealant that would help prevent in a case like this and maybe buy you a little more time to finish the case out, or maybe do it on all the cases. I don't know. I know the fluoride varnish, if you just use varnish and you apply it, if Ortho applied it every month, paper out of Germany, you got significantly less decalcifications. But if you did a combo kind of a thing where you surface sealed in the beginning, and this has the antimicrobial aspect to it. I mean, I don't know what the biofilm would look like. I don't know whether the Perrier would be better. I mean, those are all questions. So you can think about that for discussion. But I think that's a cool idea about doing that, perfusing those or sealing those, and there's going to be some perfusion there because you're going to etch it. It's going to penetrate a little bit. Those are neat ideas about managing this, because my goal is to prevent it in the first place, and then I have to worry about all this other stuff, because these can be super challenging to try and get a good aesthetic result. And sometimes they're cavitated. You got to restore them, and that's a real pain too. So states, and you guys probably know this better than I do, but states over the pandemic also changed some of their coverage for silver diamine fluoride. I know New York came online, some of the others, but some still don't. I don't know, and I usually get my data from you guys. But in North Carolina, they actually did change. This is so 1354 code, and I don't know if anybody's paying for 1355 yet. And again, you guys might know that's new, but we had trouble getting, didn't have trouble. We were pretty early adopter. Our Mark Casey here, who runs the Medicaid, is very preventive and pretty proactive about doing this. So that's what the reimbursement, and that was the original that they had. It was up to 5 years old. When the pandemic hit, they took off the age limits and they increased reimbursement by 5%. So it was $27.50. So, you know, I could buy one more cheap beer. That was about as far as it got me. But it's not about the money. The fact that they took off age limits. So we're actually lobbying them now. I've been in conversations with Mark Casey in North Carolina Dental. I'm on a prevention committee to try and have them keep this. They originally were talking about doing it when removing it when the emergency status went away. Well, we're still in emergency status. I had heard they might pull it in January, but I have not heard that they did. And we're trying to get them to put this in forever. New York, I saw they had it for up to age 20 that they would cover, because there's a whole lot of people that we can do SDF on that are special needs, even the elderly. I mean, anybody on Medicaid really could benefit. Certain segments of those populations would certainly benefit from of at least having that as an option. So switching to Pitt and Fisher caries, again, this is a huge part of the caries burden in the population. And it was an issue from a pandemic and aerosol, because we usually slather a bunch of pumice around on these things to clean them up beforehand, which throws stuff all over. You have to etch them and then you have to rinse them. But you can do these. No, that's out of kilter, the 1355. And that would be, yeah. So I just put this one in because we actually propose to do this with SDF on newly erupting teeth. So it is part of the Pitt and Fisher management. If you have newly erupted teeth, but you can't get a sealant on, or the kid's not cooperative, but you think that tooth's going to head south, treat them with SDF until which time you can get in there. Or if you're screening them and you're going to bring them back, maybe you SDF it right then if you think that tooth is starting to become carious, instead of, certainly better than doing exploratory surgery on the things. So it's a little out of sequence there, but you could do this with low aerosol without using rotary instruments. And again, in a school-based program, which I'm involved in one of these that we got funding from Duke Endowment. In the protocol, part of it was the SDF preventive part, which would be the 1355 primary prevention. But you could toothbrush them, get the junk off, and then you could use a glass ionomer to seal them. And that's especially good if you've got operculum up on here, because resin's not going to bond as well back here. So if you got teeth like this, I'll frequently take a piece of cotton or retraction cord and tuck this back, and I can get, but if you can't get good isolation, resins, or you'll get curricular fluid even will leak out of there, and you won't get a bond back here. And that's when people say, well, I have leak, they get caries under them. Well, it'll stay on because all of this is bonded, but this is leaking, so that's not good. So this would be an option for a newly erupting tooth, or you don't have good isolation or whatever. So glass ionomers can be used for that. So part of my decision making, whether I go glass ionomer or I go resin, I personally prefer resin because the data is pretty clear that they tend to stay on better. The data is not so clear as to which one has a better outcome from a caries prevention, but the data is pretty clear that the resin ones stay on better. So if I've got operculum up on here and these are glass ionomers, then that's an indication for doing glass ionomers. In molar incisor hypomineralization, I mentioned that's another indication. I know that the study that I read about the DentaShield is that the retention rates were similar to, it wasn't a superiority study, but similar to some of the others that are on the market. Again, you've got your antimicrobial in there, which I think is a cool direction to head on that. So, and we know that they work. This is from the ADA's NAPD recommendation, but it's still not readily adopted despite evidence-based. A lot of people don't do it. Non-surgical approaches, art has been around forever. Smart came along, and you guys have the glass ionomer for that. So I do quite a few of these things. There are people that have the little hand drills where they'll take round burrs and stick them on hand instruments. If you look at the SDF blog, and I know Kevin's on there, that have all kinds of ways, tricky ways, clever ways of doing some of these things. But they've been around for a long time and it works. And it's great in little kids, especially for me, because a lot of times it's atraumatic. You know, I can get in there and do these things and they leave with having a very good experience. And again, you may be only stabilizing a 3-year-old until they could be 4 or 5, or it may be definitive, depending on how well it holds up and what the lesion is. Some studies, this is a systematic review showing they hold up as well as amalgams. I don't know who puts the amalgam in, but it looks pretty crappy, isthmus fracture. Small ones do better than big ones. True with everything, but small ones, again, if you can get them in and get them early, they work really well. So do a lot of this. Then SMART was the silver diamine fluoride modified atraumatic. This was and these are codes that are many people will cover. Medicaid in our state will cover these. So again, we do a fair number of these things as well. This is a case that Bill Meyer did, and SDF treated it and then restored it. And sometimes we do these in 2 steps and bring them back, and sometimes we do it at the same visit. So this was a study, as so many of these have come out of Hong Kong, the Chu group, and they were showing, they did this comparison between smarts and arts. So these got SDF, these didn't. There wasn't any difference in the success rate. Had a discussion with Nicola Ennis at one of the meetings. It was the IDR meeting in San Francisco, and it was asked of her, well, should you do silver diamine fluoride under all your Hall crowns? She said, well, they're 95% successful without it, so you're not going to get much more bang for your buck. So we actually, if we're doing it same visit, we don't usually do that, but if we're frequently we're doing a Caries arrest and then we'll come back and do a Hall crown. So in that case, I still think it's advantageous to stop the disease progression. MIH, global burden, 13%. Two papers now, I think, in the United States, epidemiological studies, and it's about that. One from Jeff Dean out of Indiana. This is a case where, again, smart approach. And here I think it's really, there's a couple of reasons why we do this. One is frequently these have caries around in there that have taken over because of the poor structure of the tooth. It's a desensitizing agent, and then we use glass ionomer because it's going to stick in here, and that provides additional insulation and is another desensitizer. So we treat a lot of MIHs with this approach. This was a kid that was referred to me to do to take him in and do endo on this tooth in the stainless steel crown, and she was sensitive, but the tooth was totally vital. There was absolutely no reason to do root canal on this tooth. So we did the silver diamine fluoride, had her come back, and I was going to put a resin in this thing, and she came back like 3 months later to more. This was all rock hard in here at this point, and this was the residual glass ionomer. It was wearing out, and I just put more glass ionomer over the thing. She's had this stuff, you know, it's easy to put some more over top of this thing. This has been in there for like 3 years at this point. Tooth totally helpful, healthy. So avoiding doing a stainless steel crown as long as possible. If you need to do stainless steel crowns, Hall technique, which is basically snapping crowns over unprepared teeth. So this is big in Europe. It's taught in the schools. I visited Trinity Hospital this is what they do. They would almost never cut down a tooth at this point. They would go in and put separators, snap a crown on. So don't want to have, pulpal involvement on these things. So there's questions about aesthetics. I spend probably more time telling parents that stainless steel crowns are great restoration of the back teeth, and they don't need to have a zirconia crown on those things. So we're telling them the black teeth are black is the new beautiful in addition. We did a video about that, but anyway, this is a case. First mandibular, first primary molars, little kids. It's a great option, and snap them on there. And we put some topical around the gingiva, but no prep. And the occlusion, sometimes it's a little bit open, but kids will equilibrate really fast, and sometimes they're actually not even open. Stainless steel is like super thin. So, and you can check by the bite on their canines, and so look pretty good. This was an actual comparison of drilling, not drilling, traditional versus Hall, and they had the exact same success, which over 3 years, roughly 2.5, it's like 90%, 95%. So it's super successful if you're doing it. I showed this because you've got materials where you could play in this realm. So this is an anterior kind of Hall approach. I had done all these are zirconium, and these are this is a kid with a hereditary problem. You see the tooth's really brown, all the teeth are like this. And this came off. I lost one of my crown, and she really wanted it. So I got a strip crown, filled it with glass ionomer, cemented it on there, done. And she loved it. She was all happy. Cute little tooth, cute little kid. There's others where we're doing this. Do I have those in there? Yeah. So some of these cases I do this to protect the teeth, and others they're caries. This is another hereditary one, but these teeth were breaking down, and just again, strip crowns, pop them on there, let them set. These are resin modified. One of the reasons I like resin modified is I can hit it with a light. I don't have to wait. Even with a really fast set, they're not as fast as a light. So these are resin modified, but you could do them with the others, but that's why I use resin modified. Had a resident did this on caries, and one of the advantages of the non-resin modified is even more opaque. So if you were to SDF something, these were, I just freehanded this one. I ended up doing this one too, but I kept this kid out of the operating room. I never had to go and treat these and put crowns on them, which would, in the old days, that's what I would have done. So these are glass ionomer Hall crowns in the anterior using strip crowns. I think this was freehand, but I think these were strip crowns. So he did that on a case, and they hadn't even thought about that as an option. And the parents were so thrilled that the little kid, it was a 2-year-old, had these teeth now recovered. It was maxillary anteriors. They looked great. And so that's an option for doing sort of Hall crowns in the anteriors. This was a paper that's getting ready to come out where we were looking at why did dentists adopt or not adopt these different kinds of techniques. We specifically asked them about like SDF, Hall crown, sealants. It was all about non-surgical caries management approaches. And you can see the sort of hierarchical. They said patient safety was first, and then caries risk and these things. Evidence-based was one that they said was, you can see the comments down below, but evidence-based was one that they thought was important, that they talked about, but in reality, like sealants, a lot of them, despite evidence, pediatric dentists do a lot of these, general dentists not as much. And the population of the folks that we interviewed, they were doing a lot of sealants. Most of them were doing SDF. SDF was readily adopted, and there's a recent paper in pediatric dentistry that talked about the claims data and showing the response and how it's continued to go up. It's true in North Carolina. I think Bo Meyer published a paper on that too. But it was interesting to see the kinds of things that would drive their decision making. And they have financial down at the bottom, but they actually looked at family income and where they might be able to, that helping drive their decision making related to whether the family would adhere to preventive measures. And it was interesting to see what was driving. And we did the study because I thought it would be interesting to know, how can you modify that? How can you change dental acquisition of new therapeutics when they come online? What they learned in dental school was an important factor. So they told me that dental education needs to change and really be a little more on the front edge of these things, and not just not leaving it up to their own whatever after they graduate, because they tend to do what they learn in dental school and residency. So yeah, this one, I think the biggest is evidence-based dentistry. Hall crown, there's multiple randomized controlled trials showing they work, but very few people were doing it. And it's been very controversial in the United States. So I thought it was interesting. So we have all kinds of safe and effective things. Oral health care has changed, continues to change. I'm actually super proud of the way the profession has adopted and been able to continue to go back to providing care and do it in apparently, based on all the evidence, a safe and effective way, even with aerosol generation, which we're trying to limit, but we certainly can't do away with it. So we have a lot of different tools in our armamentarium, and it continues to grow. Things to assist in caries management and either get them on either keep them on a health trajectory with primary prevention, or things for secondary prevention and other therapeutics to really manage the oral health of these patients. I think it's super important in vulnerable populations. I serve on a craniofacial team, and we do a lot of these things, around cleft sites and things that are challenging, can be challenged restoratively, and we can manage with some of these therapeutics. School-based programs to get out there and really impact kids and try and get them on a health trajectory as they're moving through their life cycle and set them up for a lifetime of oral health, instead of in 20 years still having 80% of high school graduates having restorations or untreated caries. This is what we do, and I appreciate what you guys do in helping us